As you've already heard from Dr. Noe and Dr. Waterhouse, anticonvulsant agents are associated with many different adverse events. There are limitations to what studies can tell us about these events, either because of short duration of action or because some of the peculiarities of the designs themselves. I've been asked to speak about some of the serious adverse events that can be associated with these anticonvulsant drugs. I like to emphasize that many of these serious adverse events are often very infrequent, if not rare. But I think in the context of a physician counseling a patient, this is a discussion that should be had with each patient about some of the peculiarities of these different types of agents. Dr. Noe and Dr. Waterhouse have specifically mentioned suicidality. Suicidality, I think, is one of the particular side effects that has been associated with many, if not all, of the anticonvulsant drugs. There is much discussion and controversy about the frequency of suicidal thinking and the significance in the management of epilepsy patients. However, I think once again, in speaking with patients, we need to be very open and frank about some of the particular complications and side effects of these medications. So, in 2008, the FDA did produce an alert, and the slides may mention this a black box warning. It did not actually rise to the level of a black box warning, but it was an alert that raised the question that there is a slightly higher risk of suicidal thinking and thoughts in patients with epilepsy. As has already been mentioned, large numbers of patients pooled from many different trials identified a risk, according to this analysis by the Food and Drug Administration, of about 0.43%. Now, when that was compared with the placebo-treated patients of only 16,000, including 16,000 patients, only 0.24%. This led to a relative risk of only 1.8. In practice, that may come up to one extra case of suicidal ideation in about 500 patients. So not a very large risk, but once again, I think in the context of a potentially fatal disorder of suicidal thinking and possibly action, something that should be discussed with families. Now, what the FDA also mentioned was that this risk appeared to be higher in patients who had underlying epilepsy versus patients who were taking some of these same anticonvulsant drugs for non-epileptic conditions, such as psychiatric conditions or even something like headaches. As Dr. Noe mentioned in her talk, not all of the medications that are in common usage in the US were evaluated in some of these meta-analyses. I have listed here on this slide those drugs that were considered: carbamazepine, oxcarbazepine, divalproex, pregabalin, felbamate, tiagabine, topiramate, gabapentin, zonisamide, lamotrigine, and levetiracetam. Obviously, there have been newer agents that have not been evaluated to the same degree. I also want to touch on some of the other potential serious adverse events. We've talked about behavior and thinking. I'm going to mention in the course of this presentation other organ systems, including the skin, the gastrointestinal system, as well as vision and the brain. The next issue that I'd like to raise, though, is the risk of rash. Lamotrigine is probably one of the newer agents, the one probably most considered at risk for rash when we have this discussion with patients regarding anticonvulsant usage. It has been associated with, as the insert states on the bottle, life-threatening serious rashes, including Stevens-Johnson syndrome, toxic epidermal necrolysis, and/or rash-related death, the so-called DRESS syndrome, or drug rash with eosinophilia and systemic symptoms. Someone argued that some of these exist along a spectrum, with the DRESS being more severe, but the rash of Stevens-Johnson's may progress to toxic epidermal necrolysis and should also be treated with caution. In a study of almost 2,000 patients between the ages of 2 and 16 years of age, about 0.8% of patients were found to develop a rash in the use of this medication. If you look at a similar study in adults, the risk of rash was anywhere from a tenth to almost half that seen in pediatric populations. What studies have also shown us is that the concomitant use of divalproex appeared to increase that risk of rash. The risk of rash, however, is not limited just to lamotrigine. Carbamazepine usage has also been associated with a risk of a serious hypersensitive reaction manifested either by rash or more systemic symptoms. However, we know a little bit more information about this particular rash. Studies have shown us that those who are of Asian descent appear to be at a higher risk for developing this rash, and that risk of rash may be tenfold greater than that seen in Caucasian populations. As I mentioned at the beginning of this presentation, the adverse events, the serious adverse events that we're talking about are much more uncommon. And in the case of the rash in the Caucasian population, we're talking about a risk of 1 to 6 per 10,000 patients. But what we do know is that with the risk of rash in the Asian population, it tends to be associated with an allele, a specific allele called HLA-B*1052. And actually, the guidance from the Food and Drug Administration at this time is that in patients with an ancestry concerning for this risk of rash, that they actually should be screened for this allele before they're started on this medication. Some studies have looked at the risk of rash and wonders whether or not there may be other indicators of someone who may be more likely to develop the rash. There has been an association with the risk of rash with other aromatic compounds. These would be some of the compounds such as the carbamazepine, but also oxcarbazepine, phenytoin, phenobarbital, and lamotrigine. However, as you'll see a little bit later in this presentation, hypersensitivity reactions have been described with other types of anticonvulsant medications that do not fall into this particular class of chemical compound. One question that often comes up, though, is if one person has experienced a rash with one of these compounds, what's the likelihood of rash with other compounds? Studies have looked and found that phenytoin, oxcarbazepine, and carbamazepine can demonstrate cross-reactivity, but it's not an absolute risk. Maybe a quarter to a third of patients who have a rash with one of those medications may have a recurrence of rash when challenged with a different medication. Lamotrigine, however, appeared to be a little bit less likely to be associated with rash if they've experienced a hypersensitive reaction with some of the other compounds that I've mentioned. Interestingly, carbamazepine and oxcarbazepine are related compounds. One might think that there would be a higher risk of rash recurrence on that medication. However, it turns out that maybe a third of patients who've experienced a rash with carbamazepine may also experience a rash when challenged with oxcarbazepine. Another category of effect of serious adverse reactions with anticonvulsants is the gastrointestinal system. We've heard from Dr. Waterhouse about the felbamate story. It was a drug that appeared to have minimal or mild side effects during pre-market analysis, but post-marketing analysis revealed that there were significant problems involving liver failure with this medication. In some of the studies, the estimated risk is 6 out of 75,000 patients could have this problem of a hepatic failure. However, as I stated, this is an uncommon side effect, but once again, the risk of the hepatotoxicity could be quite fatal. In almost 2/3 of patients who did experience a liver failure, they either required liver transplant or expired. Valproic acid is also another anticonvulsant that's also known to have hepatotoxicity. The risk, once again, has been estimated to be 1 in 20,000 in general population. However, there are special populations at risk. Particularly, those less than 2 years of age have a higher risk of experiencing liver failure with this medication. Some would suggest as low as 1 in 600 might experience liver failure. Other potential confounders with this include those who may have congenital metabolic disease, those who are already on multiple anticonvulsant therapies, those who might have an organic brain disorder, and those with unexplained intellectual disability. Some have speculated that the reason why you may see a higher risk of liver failure in these younger children may be due to an undiagnosed mitochondrial disorder that is unmasked by the effects of the valproic acid. Divalproex has also been reported in association with pancreatitis. However, once again, we're talking about rare side effects. 2 cases in almost 2,500 patients followed in clinical trials. Divalproex has also been associated with a hyperammonemic encephalopathy and actually has been contraindicated in patients who have a diagnosed urea cycle disorder. This condition has been associated in combination with divalproex and topiramate. Another risk associated with some of our anticonvulsants is the risk of bone marrow failure. The risk of agranulocytosis and aplastic anemia is 5 to 8 times that of the general population in patients using carbamazepine. The risk in the general population has been estimated to be 2 to 6 out of 1 million patients. However, in the case of felbamate, this risk is even greater. There's a 100-fold increase in this risk of agranulocytosis and aplastic anemia with this agent. The cardiovascular risk is another problem that needs to be considered. Dr. Noe has alluded to some of the potential changes on cardiac conduction with some of the newer anticonvulsants. But even looking back at some of the older anticonvulsants, namely phenytoin and its prodrug fosphenytoin, there is a risk of arrhythmia and or hypotension with infusions. This seems to be associated with the rate of infusion, and there is specific guidance from the FDA on as to how fast this medication should be infused for both adults and for children. Vigabatrin is one of the newer anticonvulsants. Once again, it too has been associated with serious adverse events, namely vision loss. This risk has been estimated to be 30% in patients. This medication, however, is in use by both adults and children. While ophthalmologic assessment has been requested and required in the use of this medication, there are some limitations as to, particularly in pediatrics, as to how well this truly can be assessed, particularly in nonverbal children or children who don't have much in the way of communication. However, nevertheless, we do need to proceed with assessments of vision, and once again, this is a continuing conversation between both parents and physicians, or patients and physicians, about the risk of the medication versus its benefit. No safe dose or duration of therapy has been defined, although in many cases vision loss has not been seen within the first 3 months of usage. Another warning from the FDA about the use of vigabatrin relates to imaging changes seen on MRI. Particularly, there have been changes of abnormal signals that occur symmetrically involving the thalamus, the brainstem, the cerebellum, and basal ganglia in patients treated for epileptic spasms. This was seen in about 25% of the epilepsy patients, in the patients treated with drug, whereas only 4% of placebo patients. Now, these findings typically disappeared once the medication was discontinued. However, at this time, it is uncertain as to what the true significance, if any, long-term of these changes are. Dr. Noe has spoken extensively about the teratogenicity associated with some of the anticonvulsant drugs. I won't comment much more, aside from emphasizing once again, we don't really know the full significance and risk associated with the use of many of the anticonvulsant drugs, but there does appear to be an increased risk with many of the anticonvulsants. Now I'd like to switch to some of the newer drugs and speak specifically about some of the particular uncommon but serious adverse events that have been reported with these medications. Once again, there may not have been sufficient numbers of patients treated with these drugs to have a true sense of the true risk of many of these adverse events. However, many of these have been given the level of warnings and even black box warnings by the FDA, meaning that they probably should be reviewed with patients, and at least they should be made aware of these potential risks. The first medication I'd like to talk about is pregabalin. Post-marketing reports have identified a few episodes of angioedema, which were life-threatening. Therefore, the recommendations were to consider avoiding this medication in any patient who's had a history of angioedema or use of any drug associated with angioedema, such as ACE inhibitors. I had mentioned earlier that there has been some association with aromatic compounds and the risk of rash. However, in the case of pregabalin, there have also been reports of hypersensitivity reactions associated with this medication. In animal studies, there have been reports of a high incidence of hemangiosarcoma seen in 2 mice strains. In human studies, there were 57 cases of new or worsened tumors over almost 6,400 patient years in patients 12 years or older. However, no control group was available to give a better sense of the actual risk. There has also been a reported risk of physical dependence with this medication. As you'll see for many of these new medications, there's no data about the safety and efficacy in children or in patients less than 18 years of age. Rufinamide is also one of the newer medications. Once again, there have been case reports of hypersensitivity reactions associated with this medication. There's also, in some of the early trials, almost a 1% risk of status epilepticus in patients treated with this medication. There were no cases in placebo-treated patients. As you will see, for many of these medications, there are effects on cardiac conduction. Patients who have a familial short QT syndrome have a higher risk of sudden death and atrial fibrillation, particularly when their PR interval falls below certain thresholds. As Dr. Noe mentioned, this medication can also decrease that PR interval and is therefore contraindicated in patients who have this underlying diagnosis. Safety in children for this medication in Lennox-Gastaut has not been established for less than 4 years of age. Lacosamide also has had one reported case of a hypersensitivity reaction associated with it. This was out of over 4,000 patients treated with this medication. Once again, an actual incidence cannot be calculated, but that risk does exist. More interestingly with this medication, it has been shown to bind a protein called collapsin response mediator protein 2, or CRMP2. This protein is thought to be involved in neurological differentiation and control of axonal outgrowth. I quote from the label for this medication from the FDA: potential adverse effects on CNS development, or central nervous system development, cannot be ruled out. Once again, as we've talked in this panel before, infrequent, rare events may not be adequately quantified in pre-marketing and even shortly after post-marketing trials. So therefore, I think as physicians, we have to be aware of some potential complications. And once again, counsel families, we may not know about risk today. We cannot say the same in another 10, 20, or 30 years. There have also been reports of euphoria associated with lacosamide, rivaling that of some of the benzodiazepines. At present, there's no evidence for physical dependence, but that should be something to be considered. A decreased PR interval has also been reported, and the guidance from the FDA is that caution should be used for those who have heart conduction problems or myocardial disease. Once again, safety in children less than 17 years of age has not been established for this medication. Clobazam, as has been mentioned, belongs to the class of medications called benzodiazepines, which many physicians are quite familiar with. There have been reports of abuse, misuse, and overdose with this medication. There's also a risk of physical dependence, so caution should be exercised. This medication has been evaluated in children, but no safety guidance has been established for those less than 2 years of age. And ezogabine has also been mentioned before. Once again, there have been reports, most significantly, of urinary retention associated with this medication. There were 4 patients out of 29 who required intermittent catheterization for this. All but 1 were able to urinate without catheterization safely, but this is a small risk, but once again, something that probably should be discussed with patients. There also should be some consideration to avoiding using this drug in those who already have problems with urination, prostatic hypertrophy, or drugs that affect voiding, such as anticholinergics. There have been some behavioral changes seen with this medication: confusion, psychosis, and hallucinations ranging from 1 to 9%. Some of these occurred in patients who had no prior psychiatric history. Rapid titration was felt to be associated with some of these behavioral adverse events, so caution should be used. QT interval prolongation has also been noted with this medication. Once again, those with cardiac conduction defects should be treated with caution with this medication, particularly those who have congestive heart failure, ventricular hypertrophy, hypokalemia, and hypomagnesemia. Once again, safety in children less than 18 years of age has not been established. Eslicarbazepine has not been approved in this country as of yet, but it too has some similarities to carbamazepine and oxcarbazepine. The recommendations are from the European Medicines Agency is to avoid use in those who've already had a hypersensitive reaction to one of those 2 medications, and also to those who have a 2nd or 3rd degree heart block. Much like carbamazepine, there's a recommendation that those of Asian ancestry who may be at higher risk for rash be tested for the allele of risk before starting this medication. Pediatric use has not been, safety issues have not been assessed in children less than 18 years of age.